The first one is persistent hyperparathyroidism, which says elevated serum calcium within 6 weeks of surgery. Then recurrent hyperparathyroidism, which is 6 months after surgery without normal period of normocalcemia. Then recurrent hyperparathyroidism 6 months after surgery with normal period of normocalcemia. And option D, all of the above. The basic purpose of giving you this question was to make you all oriented with the definition of persistent and recurrent hyperparathyroidism. So, what is your definition of persistent hyperparathyroidism? So, what it is? It is an elevated serum calcium within 6 weeks of surgery. That means a patient who had presented to you with a parathyroid disorder, you have operated and done the surgery for the patient, but the serum calcium has elevated within 6 weeks. That means there is a persistent hyperparathyroid disorder in that patient. Then what is your recurrent hyperparathyroidism? In recurrent hyperparathyroidism, you have operated on the patient and the patient has a normal period of normocalcemia. That means there is no raised serum calcium during that period, and the cutoff for this is usually 6 months, right? So this is your recurrent hyperparathyroidism. The basic purpose was to introduce you all to the definition of persistent hyperparathyroidism and recurrent hyperparathyroidism. So the answer over here would be option B, which is without normal period of normocalcemia, because in recurrent we find a normal period of normocalcemia. Now, coming down to hyperparathyroidism, I would want you all to know some important topics with respect to it. The first is itself the classification of hyperparathyroidism. So, we have three types. One is your primary, then your secondary, and third is your tertiary. So, what is your primary hyperparathyroidism? One thing very common in all three of them is that it has increased PTH levels. Now, what happens in case of primary hyperparathyroidism? In case of primary hyperparathyroidism, there is an increase in the PTH level due to the defect in the parathyroid gland itself, which causes the loss of feedback inhibition. In case of secondary, there is increase in the PTH due to the abnormal production of PTH in a normal gland. The catch over here is that the gland over here is normal. The parathyroid gland is normal and there is no loss of feedback inhibition. So what happens is that there is a systemic hypocalcemia and hyperphosphatemia which causes a chronic renal failure. Hence, the secondary hyperparathyroidism is often called as renal hyperparathyroidism. Then, regarding your tertiary hyperparathyroidism, there is an increase in the PTH level due to the activation of chronically stimulated gland. It usually occurs in patients of post-renal transplant. So what happens in such patient is that the feedback inhibition of parathyroid is rejected and there is a supraphysiological activity of parathyroid gland. You could get a match the following question from this topic where you would be asked about the definition of primary, secondary and tertiary. Please remember that in case of primary the gland is abnormal, in case of secondary it is absolutely normal gland, it is often called a renal hyperparathyroidism, and in case of tertiary it is usually in the post renal transplant patient. Now, in case of hyperparathyroidism, there are some metabolic abnormalities which are associated, not metabolic, rather biochemical abnormalities. So let's look at them. Now, on this side, we have the parameters, then we have the primary, secondary, and tertiary. As said, for all, your parathyroid hormone levels would be increased in all of them. The calcium levels are going to be increased in your primary. It might be low or normal in case of secondary and high in case of tertiary. Phosphate levels are decreased in primary, increased in secondary, and decreased in tertiary. Vitamin D is raised in primary, low in secondary, and low in tertiary. You would be getting a clinical scenario where you would be given different values and you would need to diagnose the type of hyperparathyroidism. So please remember this important chart from where you could be able to solve all the questions of hyperparathyroidism. Now, over here, I have also mentioned about two important tests which have been mentioned in your Bailey and Love, that is urine calcium and creatinine clearance, a ratio of more than 1. It basically rules out the familial hypocalciuric hypercalcemia, right? So if this is more than 1, it is going to rule out familial hypocalciuric hypercalcemia. Then there's a test called Casanova test, which is done in case of a secondary hyperparathyroidism. What is done over here is there is a selective venous sampling for PTH in the neck and the brachial vein on the side of graft. Now, if the ratio is greater than 20, it is suggestive of recurrent disease. Right. Now, another important topic in case of your parathyroid is your pre-op localization. Now, over here, I would like to just remember this important points mandatorily, which is the use of sesatimin scan. What it is nothing but 2-methoxy 2-methyl propyl isonitrile. Right, it is the most accurate and reliable method. It usually has almost the same sensitivity and the specificity like the ultrasound, but it images the ectopic gland better. Now, in case of USG, remember that parathyroid are hypoechoic in nature, and the giant adenoma size, the cutoff is taken to be 3 centimeter. Right. Then there is a 40 CT where you need to remember that the fourth component that has been added is the functional component, and we have a criteria known as a Miami criteria. What happens in this Miami criteria is that it is used intraoperatively. Once the surgeon takes out the diseased parathyroid gland, what is expected is that there is a fall in the PTH level more than 50% from the baseline value after 10 minutes of successful removal. So if you have removed it successfully, then after 10 minutes there would be a drop in the parathyroid values for more than 50%.